All right. So we will start very quickly with some introductions. You can just let us know your field that you're precepting from. And I'm going to call out names just to make it go smoother. So we'll start with Dr. Lashley.
Hi guys, I'm Mark Lashley. I'm practicing in Valley Stream and in Rockaway. I'm a general pediatrician and I'm part of Allied Physicians Group.
Welcome. Dr. Laxer.
Hi, internal medicine in Roslyn. That's it.
Dr. Batista.
Hi, I am in a pediatric practice in Garden City. I'm also part of Allied Physicians Group.
Dr. Wilson.
Hi, Lee Wilson, internal medicine. I'm the medical director at the World Trade Center Health Program, and I have students from Hofstra come and see the World Trade Center Health Program patients with me.
Perfect. Dr. Sharavu.
Hi, everyone. I'm a pediatric endocrinologist, and I'm happy to be part of the faculty I joined in September.
Dr. Packer.
I'm in medical ethics.
Dr. Siniglia. I think I always mess up your name.
No, it's perfect. Rose Siniglia, Mineola, general pediatrics.
Also my kid's pediatrician. Alicia Arapalo, Dr. Arapalo.
Hi, I'm Dr. Arapalo. I'm a vascular surgeon. My emphasis is in wound care, and I'm based out of the North Shore University Hospital and on Long Island Jewish.
All right. Did I forget anyone on here? Because my screen is hopping around. Dr. Forneri, do you want to give any more introduction to your 300-page repertoire, or?
It's not that big, but I'm in a pretty reflective mode because I'm following this talk with a talk on mentorship, and I feel this is a form of mentorship, what I'm doing here right now. I'm trying to mentor all of you to who have teaching skills, everybody who's introduced themselves. I don't know every single person, but I know many of you. I'm a little embarrassed to be talking even to Sam Packer about this. He's been a colleague and a friend way before I came to Zucker. And all of you, I'm very happy to deliver a passion about medical education. I dedicated my talk tonight that I'm giving after this to my mentor who found me really out of the med ed world and brought me into it. And she's a family physician in primary care. And the topic we're doing tonight, 1 Minute Preceptor, I really call it 5 micro skills, comes from the family medicine literature. It was 1983 that a person wrote about this, and it became a reality in busy ambulatory settings. So all of you, most of you, work in busy ambulatory settings. So it's the perfect little talk to have together to try and figure out how to teach in those busy little settings. So I just want to say I'm thrilled to be here. And of course, Dr. Aristide, do you go by Jermaine Aristide or just?
You can just say
Razia. Do it?
You can just go with Razia.
Razia and Sunita are colleagues of mine, and I'm really always glad to partner with clinicians. I always say that I'm always so much better when I have a clinician at my side. I am a clinician in another life, but you know, having a physician clinician by my side is always better. So they'll be part of our presentation, and I hope this creates a discussion about how this can be helpful, we hope, to teach in the busy clinical setting. So thank you.
So for those of you who do not know me personally, I am an internal medicine based previously in the ambulatory world, currently in the inpatient world only, and in 2020 only in COVID land. So that is me. I still do practice clinically as well. Before we continue, I just wanted to make this statement, which we have to from the joint CME world. So in support of improving patient care, Northwell Health is jointly accredited by the Accreditation Council for Continuing Medical Education, the Accreditation Council for Pharmacy Education, and the American Nurses Credentialing Center to provide continuing education for the healthcare team. This will give you 1 AMA credit. Northwell does designate this internet enduring material activity as well, which means that we are able to offer this as a live session. Moving forward, you can claim these credits utilizing these skills for whatever amount of hours that you utilize the skills to teach your students. The beauty being that you are able to get a double credit for the 1 hour of time taken to teach your students. So 1 hour is designated as learning, 1 as teaching. You spend an hour, you get 2 credits. Just for program information, this is part of the bigger umbrella of the overall program, which is really to support and enhance teaching skills of the faculty involved in the preceptorship. There is a series that has a very similar goal, and within the series, we are utilizing 4 different sessions every quarter to give some skills here and there for preceptors to teach in the clinical setting. The live program obviously is today, but the recorded one will be tomorrow. It'll expire in 2021. In the chat box, Sunita will be taking your name, credential, and email address just to make sure that we do not miss anyone's attendance in the event that you are not able to fill out the survey. They will be sent to you following this session, likely tomorrow. No disclosures at all. Michael Parrish, who you've been receiving emails from, is the program coordinator for all things ambulatory. And I do want to apologize ahead of time because this is actually my first time using a poll everywhere. So I'm going to try to attempt to do it. What I wanted to start with a discussion with before Alice delivered her content was just to talk about some of the barriers to precepting. I precept both from formerly in the outpatient and now in the inpatient setting, and I'm aware of all the barriers given the current times especially. So I just wanted to find a common ground with everyone regarding that. So we are going to take this opportunity to do a poll everywhere, but I would like to share this screen.
One person joined Razia since introductions, just to let you know.
Oh, okay. So this is activated. Please let me know if you're able to text message some responses. I'm going to try as well. To barriers to teaching students in an ambulatory setting.
So, Razi, I think you should explain exactly what you want them to do.
So you're going to text Razia Jamin A840 to the number 37607 that's on the screen. Once you text Razia Jamin A840 to that number, it'll add you to the poll, and then you can just send a couple of words as to barriers that you have with teaching.
Thank you.
Precepting in the ambulatory world.
Some people find it intuitive and some don't.
Sorry, I'm so nervous about doing this now. It's my first time doing it.
I could relate. I'm very nervous. I'm doing another thing at my talk next, and I'm very nervous that it's not going to work. So don't worry, because I'm equally as nervous as you are about what I'm doing in my next talk. It's not a poll, but it's technology.
I know. I'm such an anti-tech person. If there are any issues, you can yell out responses to me and I'll text it.
You can just write it in the chat.
Yeah.
There's always the chat.
That's right.
All right, I just texted and I got back a reply already.
Okay.
Mine says it could not be found.
So you texted Razia Jamin 840 and you texted to the number 37.
Yep.
There's A between the N and the 8 is what I think is forgotten. So it worked on my end.
Wait, RAZIA.
JAYMAN A 840.
Oh,
Oh, there's no A on
there's
your
no A
No A.
on your screen.
Razia, there's no
A
A
on
on
my
your
screen. It's showing an A on mine.
It's not on this slide.
It's not on the
And when I
Okay,
my
that
reply
works when you-
says
When you put the
keyword
A in, it
Razia
works.
Jamin 840 cannot be found. So I'll try texting again with the A.
Yeah, with the A, it works.
That's so odd, the screen that I'm looking at.
Isn't that, I don't understand, because I'm looking at the same screen as you, I hope, if we're in the right world, Razia.
You know what it is? In your poll, it has an A in the end, but in the part that you wrote text, there isn't an
Oh,
A.
that's correct.
That's what I'm seeing.
Technology. Please feel free to also send out some responses and then I can put it in through the chat.
Okay, so I have that I've joined.
Yeah, me too.
And now you want me to send you
Any words that come to your mind when you think about barriers to teaching students in an ambulatory setting? Okay, so we have time, limited, mostly constraints, busy, tough, RVUs, schedules. Limited exams. I'm so excited it's working.
Rosie, we're supposed to see the exam responses. Why are we not seeing it?
Are you not seeing it?
No.
Correct.
I don't know what is happening.
You may need to share your screen.
I'm getting more anxious about my next activity because I feel like I'm going to be you in a few minutes.
Okay, let me.
But we're not seeing it.
Share.
Do you have to refresh your screen maybe for it to show?
Okay, I don't know what happened.
Okay, you could just read them off. Is there a theme, Razia?
All right. Are you guys seeing it now?
There it is. Yes.
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 Well, okay then. So there we go. The theme seems like predominantly time, busy practice, which is also time, constraints, schedules, time, maybe patient refusal, vacations, exams, practice. Seems like they're pretty geared towards time constraints. We did have an additional join, Toba Weinstein, Dr. Weinstein. We were just doing introductions earlier, so if you don't mind just telling us what field you're precepting in.
Pediatric gastroenterology.
Ooh, hefty there. Thank you so much. Welcome.
Thank you.
All right, so I am going to stop this share. Alice, we got a decent amount of information, yeah?
Right, and we know, so we're talking about teaching in a busy setting and time limited, so I think we're on target.
Okay, perfect.
Okay, so
going
we're ready
back
to go with the deck?
Yes, ma'am.
So tonight we're going to talk about 1 minute preceptor, and I call it 5 micro skills because I don't think anything is 1 minute. Maybe you can't even boil an egg for probably 1 minute because you'd overcook it. 1 minute goes quickly. But we're going to talk about the 5 micro skills, which is the other term, and we're going to talk about the steps for that, and then we want to talk about how to use this very specifically also to expand the social history to address social determinants of health with the patients. So we have a very big focus right now at the medical school to address social determinants of health. We have it spread throughout, I'd say 2 solid years of the curriculum, and we're going into the 3rd year. I actually ran a focus group today with faculty. We're trying to develop a curriculum in social determinants of health in the 3rd year of medical school. And I ran a focus group earlier today with internal medicine faculty about that. So social determinants of health is something we'd love to bring into the ICE setting more vividly, I should say. And obviously with certain patients, it's more representative and important, but it's really important with all patients. And unless you ask, you don't know, because no one tells without asking generally. They somewhat put a mask on and they don't tell or remove the mask until you ask. So the ask is really important, and we want to teach the students to do that, and we'd love you to help us to do that. And you could do that through the 5 micro skills approach. So that will be part of today as well. Any questions, complaints? Okay, let's go. So Rosie, you want me to skip the video for now? You're muted.
Razia, you're on mute.
Do you want me to skip the video?
Yeah, I think we should skip the video.
Okay.
We'll get back to it towards the end.
We could go over it in the end. It's a cartoon video, which is which demonstrates this. So I think it's actually quite nice. So maybe we'll use it as a conclusion. So the 1 minute preceptor model, as it was called, and I don't know why he named it that, but it's really 5 micro skills. So you have a patient encounter, which you all have. And the first step is you get a commitment. from the learner, what do you think is going on? And that question that you ask that way is very different than saying to the learner, what do you think the diagnosis is? It's a different question. What do you think is going on with the patient? It's a much more open-ended question where you're not pinpointing them to narrow right into the diagnosis. And that's really important. Now you're going to say to me, well, that takes a little more time to do that because I need to get to the diagnosis. But in terms of a learning process, we want to open it up like that. After they say to you what they think is going on with the patient, because they did interview the patient, hopefully, and history at least, what led you to those conclusions of what you're thinking? This is the probing evidence, the clinical reasoning behind, and this is a really important step. And it's probably the step that we don't do quite as much as we should, because they might give us a commitment. Well, the patient has a cough and it's dry and they smoke, so it's probably secondary to their smoking, but they don't want to stop smoking. So at this point, maybe we could break up the cough with some type of decongestion or whatever, and everybody's already moving forward. But thinking what led you to those conclusions? What is it about the patient's history? What is it about the smoking? What is it about perhaps something environmental? Do they have a history of asthma? How long has the cough been going on? Is it persistent or onset? All those things. So understanding the probing evidence for what they're talking about is really, really important. And this is the step where you get at how they're thinking, and it gives you the opportunity to then think, and I have to say, I want to go up to the top right first. What would you like to teach this learner? Because you should begin to think, what is going to be my one teaching point for this learner? And I use that number one very, very seriously. Obviously, with every single patient, there is so much you could teach. There's an A to Z alphabet on what you could teach. It could be about current history, past medical history, family history, social history, medications, allergies, so many different things. But you have to pick one thing on the spot for that person to teach, for that patient. And that's the hard job. It sounds easy right now. It doesn't sound that hard. But when you're in the moment and you have to come up with it, because you can't plan what you're going to teach, because you don't know what the patient's going to say to the student. You don't know what the student's going to say. So you can't pre-plan your teaching. So it's an in-the-moment teaching opportunity. If you don't do this one-point teaching, and I say limit it to one for the exact reasons you put in your word cloud, we don't have a lot of time. You can't teach endlessly in this environment, but you can teach one thing through each patient. And if you teach one thing through each patient, by the end of the time they have with you, they've learned a lot. But your job is to figure out that one teaching moment. That will take you 3 minutes, what I just described. Get a commitment, probe for supporting evidence, and they talk to you. And if they don't talk to you, you have to probe more, and then teach. That will take 3 minutes. If you're really rushed, you are done, and you move on to the next patient. If it's a day where it's a little slower, and I don't know if that ever really happens, I can't speak, but if it does happen for some reason, you can give the student immediate feedback about how they felt the interview went, what they felt they did well, and come up with what they would like to do to improve. You're not going to be able to do that with every encounter. We don't expect it. But if there is a moment of extra time, or if it was a very challenging encounter and you want to go over a little bit of feedback with them for whatever reason, maybe it was a parent. I have a lot of pediatricians on this call. So maybe it was a parent who was refusing a vaccine. And I'm bringing that up because we have the vaccine front and center right now with lots of people talking about what they're going to do with it. So, you might, if they're refusing a vaccine, that might be in a very challenging encounter for a student. And you might want to take a minute and say, so how did that go for you? And I saw that you really empathized with the patient, but you were also able to give the facts of why the vaccine should happen. And that was good, but you didn't lose your empathy while you did that, you know? Or perhaps the student came across as too dogmatic and was not empathetic, and you want to give feedback about that. I mean, I can't predict what it's going to be. That will take an extra 2 minutes. So I'm talking about the 5-minute preceptor here, not the 1 minute. And I'm talking about the 5 micro skills. So the opening question is 1 micro skill, probing evidence is the 2nd, teaching is the 3rd, and then reinforcing what went well and what could be improved and how they could self-direct their learning is the last step. 5 micro skills, 5 minutes. In order for you to become good at this, you have to practice. I always say this, I think I said it last time, but actually I think we had a different group here than this time, if I'm not mistaken, if I have any memory in my brain. And I can't give you the gift of time. I have no time to give you. I don't have any time to give myself, so I certainly don't have time to give you. But I can give you skills that make you better. And I always go back to like driving. So the other day I get on the Meadowbrook, it's bumper to bumper. I quickly get off the Meadowbrook. I do a U-turn. I take all the back roads and I get to Northwell because I'm a good driver and I know the route. So I have a lot of skill to make that alteration. I have a colleague at the medical schools who's very trepidatious about driving, very fearful. And she knows one way to get to Northwell from the medical school. And that's the only way she could do. And it takes her double the amount of time as me. If we leave the exact same time, it takes her double. So the issue is she doesn't have the skills of driving. She's been only driving for 5 years. So as you develop your skills, you can do things more quickly. And it's not that you don't do them in a quality way. So you must practice. So next slide. This is the same concept here. Everything I just said, if it's easier for you to see, where you get a commitment, you probe. These are some questions. What do you think is going on? What would you like to accomplish? What other information do you need in terms of the commitment? Probe for evidence. What do you think? You do get to the differential at this point. Then you have your teaching point, and then if you have time, feedback. Most likely this is done in the hallway, and if you don't do feedback during the encounters, you can sit back at the end of the day and say, well, of all the encounters I saw today, why don't we discuss this one encounter for feedback? It's nice to do at least one feedback moment in a session. And you could say, you know, based on all these patients we saw, I saw this one as the most challenging. Why don't we talk how that went for you? And pick one patient. The student will really feel that you're concerned about their learning of clinical management in the ambulatory setting. So I'd like to stop for a minute and get some feedback from all of you. What are you thinking in what I'm talking about? Does this sound like, you know, this is what I do all the time, or this is a deviation?
Well, you've definitely given me some good points, but it sounds a lot like what I do all the time.
Yeah, what about doing it in the presence of the patient?
Okay, that's teaching at the bedside. We're doing a session on that in the future. This is teaching outside the room. There are 2 ways you can teach, and thanks for bringing that up. You can teach at the bedside, but you wouldn't do this technique at the bedside with the patient. You do it differently because you want to involve the patient when you're doing that. Now, I know you're in pediatrics, so we're talking about 2 patients in the room. We're talking about the parent and the child. So that's a whole nother conversation. But teaching in front of them is different than this technique. This technique I'm talking about was designed to do in the hallway in busy clinics. Mark, I'd like to go back to your statement. It sounds like what I do all the time, which is great. Do you find any challenge in what you do all the time?
Well, a lot of the time it's that I'm operating at this level, and then I realize who I'm talking to, they're operating at a whole nother level without, we don't have a common understanding.
That's
So
where that first piece is so important, because if you ask the learner, what do you think is going on? That very first piece, what would you like to accomplish with this person? Right away, you know where that learner is mentally. Are they with you or they're not with you? Are they thinking ahead of you, or are they thinking, below you? So you're calibrating with them. But if you don't ask that first moment, that question, you don't know where the learner is, and therefore your teaching might be off base. Also, this makes the learner speak first. So in terms of psychological safety, and I bring this up in every talk I do now, psychological safety. Learners feel nervous. Learners feel hesitant. How can you make them feel psychologically safe that they're in an environment where they can make a mistake, obviously not a big mistake, hopefully, but a small mistake, or not be sure of something and have to ask a question, whatever it is. When you let them speak first, they feel they're part of the conversation. The minute you start speaking and saying, well, that's not what I was thinking, or I think we need to do this, or I know this mother, or, I know this kid, and you start speaking, right away they shut down and say, okay, he's going to tell me what to do, and I'm just going to do what he says.
well, when they first come in on their first day, I have a talk with them and I say, listen, I'm not here to really judge you. I'm here to help you learn how to think. And I say, there are no stupid answers. I say, we're here to learn. I'm going to help you think like a doctor and just get a taste of what it's like to be here and to be me a little bit. And we're going to have a lot of fun times together and learning, and anything you want to ask me is fine. And I said, I'm not here to judge everything you say. So I try to put them at ease from the get-go.
That's good. Excellent. Thank you for sharing that with your colleagues. That's setting expectations, which was the last talk we did. I don't know. I don't think you were there. I'm not criticizing you, but we did a whole talk on exactly what you said, Mark, which was how to set expectations with the learner. So that's great. And that creates psychological safety. But this importance of this model, these innuendos of this, is getting the learner to speak first, getting them to bring out what's in their mind, even if they're uncertain. And then that probe. So why are you thinking about that? Well, it's winter, so in the winter season, you have to think about these things, or it's allergy season, so you need to think about these things. Why are they thinking this way is that clinical reasoning piece. Anybody else? Sunita, Razia, chime in. Anybody else?
So Alice, I think, when I was when I did the internal medicine program at Forest Hills, we used to have residents who would always talk about how we never gave them feedback, right? And we did nothing but give them feedback. And one thing that I learned in one of those sessions was that, you have to start off with, I am giving you feedback now, and then, proceed with feedback, which at the time I thought was kind of silly. But I started using that a little bit in teaching, like when I teach residents at the bedside, and I don't know how the day is going to unfold in an inpatient setting. I remember one class a few years ago where I did nothing but teach, right? So we had 15 to 20 patients. I taught on every single patient. I demonstrated physical exam, percussion, everything, right? And at the end of it, this resident turns to me and says, I feel like we don't get any teaching here. And I was just mortified, right? And so I realized that, kind of in the beginning of rounds, I would talk about a couple of things that we were going to learn, and I would do this probing with them. And I would end it with, so we discussed X, Y, and Z, and this is how you rationalized it, and this is how I'd like you to think about it next time. And I think that helped with the learners feeling like they learned, because like Dr. Lashley said, we do this all the time, right? We teach all the time, but sometimes, when you're teaching at the bedside and they're thinking about 5 different things, I think they don't receive it as teaching unless you have such a structured, this set of, 1 to 5 minute precepting is a structured format for teaching, right? And I feel like learners tend to think that they're getting learning when, or getting the teaching when they have such a structured format. So I use it constantly in the inpatient setting, but I also pre and post it with, this is what we're going to learn and this is what we've learned. So that's how I tend to use it.
That's why coming up with the teaching point. So this is the time for you to be the sage on the stage, you know, at that moment. So it's the student doing the first 2 steps here. Then suddenly your voice is coming in and saying, well, let's talk about this. You know, if we did this antibiotic versus this antibiotic, or if we did a rapid strep versus a regular strep. I don't know. I'm trying to think of pediatric stuff, you know, whatever, you know. So teaching an important learning point, and because that's students all to say, you know, I was with the doctor all day and he didn't teach anything, or I didn't get any feedback. And, you know, this is common and it happens all the time. So being very deliberate. I don't think you're going to do feedback on every single encounter. And I think feedback at the end where you pick a case or you pick a situation, I think is excellent. I mean, it's not global feedback. You did a great job today. That's useless to the learner. Or I'm glad everything worked out so well today. See you next time. That's useless feedback to the learner. They don't know what that means. But sitting down for a few minutes and reviewing one case or just a few issues.
I don't know if I agree with you, Alice. I think that
Go ahead. Disagree.
a lot
I
of
love
the
that.
students I see are filled with self-doubt.
Yes.
And, reassuring them that they're on track, that they're doing fine, that they're learning, that they're doing okay. I find they check in with me a lot, like, how am I doing? And
Great.
I don't think it's useless to say to them, you did great today. I think I try to say that at the end of every day with them. Today was a good day. You did great. Look what you learned. Look what we did. You know, I try to do that at every session.
Yeah, but you just added a few words, Mark. I'm listening to everything you're saying. You said you did great today. Look what you did. And then you ... Look what went well today, ... Look at the diversity of patients you saw today. Look at the different scenarios you saw today. So you're ... dotting that. But just to say good job today,
Okay, yeah.
it is known in the literature, I could show you study after study, that a learner does not want to hear, read more, good job today. They want to know some few points. So you already put the ... in, and you got rid of some self-doubt that, you know, I really can't do this, or I'm not so good at this. I can't work with kids. And you might say, you really did a great job. Look how you talked to that parent today.
Yeah.
And that's different than just you did a great job today. So I
what
think
you're
we're on
saying.
the same page.
Yeah. Mhm.
Can I, Alice, just a question. So a lot of times with my students that come in, I know this is going to be the first case of that type that they have seen. So I'll say, this is a really interesting case, and we'll look up that child's history before we even go into the room. So I feel they get a lot more out of, we kind of review what to look for, what the changes are, what kind of medications, and then we go into the room. And I feel that they're more of an active participant because they've already had some feedback before they even went in.
So that's teaching, you know, getting ready to, that's the prep step of getting ready to teach at the bedside. So that's great, Rose. Mm-hmm. Where in order to get ready, and that's a talk that I will be having here at some point, but teaching at the bedside, you want that prep stage. And most people don't do that prep stage. So I congratulate you ahead of time that you're doing that, because most people say, just, you know, we'll go see the patients, follow me around, you go in, the student's like sort of lost, you have the whole history in your mind, they don't know what's going on, they're thinking things, and you're like, you know, that's not right because you know the history. Mm-hmm. So you're doing that prep stage before going in, which is part of bedside teaching, or I call it teaching in front of the patient. I like that better than bedside teaching for some reason.
Okay.
That's an excellent thing to do. This is more when you're letting the student go on their own and they're precepting out to you. Does that make sense? You know, when the student
do a combination of both. It depends on the case.
Of course, both. It's not like one skill fits everything. Mm-hmm. You need, you know, it's like, you know, like anything else, you need a tool chest.
But the
so
kids,
this is called a.
The students are also comfortable in telling you what they're not comfortable with or what they've had no experience with. So that also gives you a guide as to what you have to do with them.
So that's part of setting expectations, and that's an excellent thing where you say, I think there's 2 quick questions you could ask every student. How many times have you been in a setting like this? And how many times have you seen patients like this, whatever that is? You know, it doesn't matter, you know. And I think once that gives you right away knowing how much comfort they're going to have. And this is especially important in pediatrics because many of them have not interacted with children, and their prior experience to medical school might have been more adult oriented than children. It just depends, you know, what they were interested in.
You know what I find they have a lot of fear about? Anything to do with genitalia or sex. I don't want to sound weird about it, but I have a very hard time getting students to examine genitalia or how to do a testicular exam, or I mean, especially females sometimes, and counseling teenagers about high-risk behavior. It's very challenging to try to get them to come out with that and be comfortable with it. I don't force them, but I tell them, listen, you know, as docs, we don't get the luxury of being shy. I said, if we're shy or nervous about this important stuff, then we might miss cancer, or we might not stop somebody from conducting high-risk behavior. And I put a lot of energy into that to make sure they're comfortable with that.
I think that's wonderful. I have to say that we try to teach these conversations at the school so they're ready for you. I mean, we have the heads conversation for the heads. This is pediatric specific, so I'm sorry, Joel. But the heads exam, which goes over social, you know, the sexual history and sexual behaviors. And then we also have taught them a separate session on how to do a complete sexual history, including all aspects of it, everything, soup to nuts. Probably more than you can imagine we've taught them, I think.
I think it's just the idea.
Second-year students, so.
Well, I think we do the same thing with
Yes.
adult patients. I mean, we still have lots of people who engage in high-risk behavior that we need to.
Everybody, Sunita, you.
I was going to say, I think it's from a student perspective, I think it's the idea of learning it in the safety of your school setting and actually practicing it in person. I think that's the disconnect, though they know what they're doing. So as I mentioned, I'm a pediatric endocrinologist. So, you know, I'm doing a lot of these sensitive exams and having these discussions about puberty and whatnot. I think when they see us model it at least once or twice, then they feel more comfortable. They know what to do, but it's a matter of seeing someone in action with that patient. I don't know. I think it has a different feel. So it's wonderful that the students have the opportunity to work with you all, you know, more than just one afternoon, that they have time to understand your style and then they can model it.
So I want to say that role modeling is really, really important. So certainly a complex conversation like sexual behaviors or a complex exam like genitalia and stuff, you certainly would want to role model that to the student. And then obviously, hopefully an opportunity comes where they can role model to you again, you know, back and forth. I've heard from the students, they're very challenged by the adolescent visits. I heard that during my reflection session with the MS2s. Very, very challenged by the adolescent behaviors today. So they're just like parents are challenged. And my husband happens to be a child psychiatrist. And I heard him on the phone this morning. He was doing a patient visit at home at 7 a.m. And I was just like, I don't know how he does this every day. Like, I just don't even understand it, you know, like. Then he told me this woman has 4 children and this was only one of them. But so the students are pretty overwhelmed with the adolescents. I heard that. I don't know what you heard, Sunita, in your reflections, or Razia. I heard a number of stories about how do you talk to these adolescents?
Yeah, it's interesting. I haven't received that feedback, and I think my family group, they feel very comfortable. It might just be this particular set of students. So it's interesting to me to hear that they feel challenged by the content. Maybe they haven't had the opportunity, but the content interests me that that's a challenge for them.
And they're not that far from adolescence.
Right. That's why I'm sort of surprised by that.
So in the interest of time, I really want to get to the social determinants of
Yeah,
health.
right. Thank you. I totally forgot we're doing that, Rosie. I
So
forgot.
I did want to show these JITs that Alice has, and they will be getting, if they're not already, you'll continue to receive these emails with JITs. And what I like about it is that it, when I'm inpatient and I forget all about teaching, because we're just, running around like crazy chickens. I like to pull these up and then I'll pick up one point, right? And as I'm looking at this JIT, one thing that I want to remind everyone here is the very bottom, number 5, providing coaching and correcting any mistakes. I want to remind you all that at Hofstra, really the mantra is that the students teach themselves, right? So they learn the material through self-teaching and teaching their colleagues. And we really don't give them direction outside of a few large group sessions. So we trust that they will do the research, collect the material, and learn medicine pretty much predominantly self-directed. So they really do yearn for your guidance when it comes to, your clinical encounters, when you do correct any mistakes that they have and you do give them strategies on how to move forward. And, if this happens to this patient, then this is what I do. So kind of more finite answers and solutions to problems. So this is just a JIT basically about what Alice is teaching. And so Alice, I'm going to move to the next slide.
I just want to say the coaching model is really important for us. I agree with Razia. So let's just go to the next slide. So these fit on your phone perfectly. Sorry, this is really distorted, but these fit on your phone perfectly. There's another JIT, but the top part of this JIT describes the social determinants of health. And we feel the social determinants of health fit into the expanded social history. So the expanded, obviously the social history, and especially a lot of you are in peds, but in general, also for Joel and adults is, about smoking and alcohol and occupation for our adults, or some of the kids do work also if they're working, education, all the things that are part of social history. But the social determinants of health is what we call an expanded social history. And we're really trying to get the students to access mentally things about the neighborhood where they live, how they access healthcare. Insurance, obviously, is a very, very big issue today with COVID. People have lost insurance who had insurance. Their social and community support. So this is especially important in Joel with adults. If people are sick, who is their social support? Education level. I always thought when I worked in the Bronx with family medicine, which I did for 6 years before coming here, the doctors there told me the greatest prescription they could write is for the kids to stay in school and have education. And they would write prescriptions, go to school, stay in school, do your homework, because that was the greatest gift they could give them. So education level, and then of course, economic stability at home. And it's not here, but under economic stability comes food insecurity. And today, food insecurity is a very big issue in light of COVID in general. So really, really important food insecurity. And it leads to obviously sometimes bad eating habits, or less than desirable eating habits, I should say. And this, of course, even though you have food insecurity, you can still have issues of dealing with overweight and things like that, which come from that. So next slide. Actually, social determinants of health on the JIT, you could see this nicely, account for about 80% of a person's health. And actually the clinical care you provide is about 20%. This is really scary because you think your clinical care is the most important, but actually they can't do the things you say clinically if they have issues of social determinants of health that are negative. So it is in the literature very clear. And the inequities are very big, in light of COVID, even bigger. Go ahead. And next, I just want to go over the precepting. Okay, so how do you do this? This looks much better. Thank you. So it's the same idea, is tell me about the patient you saw, but specifically to their social circumstances. So you're targeting the social history. And what questions did you ask as part of your social history that's helping to make you have an understanding of the diagnosis and the treatment plan? What can we do to help the patient with some of the social circumstances? So you're probing and providing teaching, but it's specifically about the social circumstances of that patient. So if it's a child who has to eat, usually eat school breakfast and school lunch to have adequate food intake, and now they're doing school from home, what are they doing for food, for breakfast and lunch? If it's an adult who normally would go to the senior center and they can't go to the senior center now, what are they doing to eat their major meal of the day? So you're probing based on a social circumstance. And then you would teach that teaching point step, but specifically about the social circumstance. It could be about the patient's insurance. Can they afford their medications? Can they buy food? Do they have transportation? Empathizing with what these circumstances do to the patient and their family. And then activate, this is really the hard part, where you have to come up with how do we help the patient. And actually, I did a focus group with attendings today, and they said the number one reason they don't address social determinants of health, this was attendings at Northwell. They don't know where the resources are to help people if they identify an issue. They don't know how to get the resources to help somebody, so they don't want to ask it. So there are different ways to access resources, and most of you, I would assume, don't have social workers like they do on the inpatient unit, which is of course what they said they normally do, but thinking what resources are available in the community to help people, and somehow having somebody in your office be able to help them if something's identified. And then once again, the feedback of how did that influence your treatment plan? You know, what we know about the patient and their social determinants of health, how is that going to make a difference? And then if they didn't ask any of this, then why is it important to ask this? Have a conversation around that. So you can modify the 5 micro skills. This is, I like the way Razia put this sort of in a petri dish, I call this. And really, when you look at a petri dish and something grows, we're trying to grow the social history to really include the social determinants of health. Any thoughts on this?
Alice, I just want to add to your resource concern. So what we've heard from a couple of students and preceptors when they are uncertain of how to move forward with resources is that they've actually put the students in charge of looking into it. And then the students do the research and they figure out additional resources, and then they'll call the patient back and give them those websites or resources or numbers to get in touch with. So in settings where time is a concern, you can also utilize your students so that they understand firsthand how difficult it is not only to obtain the resources, but for the patient to navigate through the resources as well.
And, you know, that is a great learning point for a student to be able to identify something in the community that's available for patients, especially if it's a reoccurring issue in your office.
Also, they'll feel like they helped someone. They actually helped someone.
I think it empowers the student.
Right. You know, yeah, I mean, these attendings said, you know, if we determine they have food insecurity, what am I supposed to do? So why would I ask that question? And they said that on Zoom recorded. Next. These are just additional JITs that we have. They're based on telehealth. I know a lot of you are not doing telehealth right now, but we had this big surge of telehealth. So we developed a 5 micro skills to Precept during a telehealth visit. It's slightly different, but you sort of frame the session of what you want the learner to do on the telehealth visit. This is not the learner watching you. This is the learner doing the telehealth visit itself, and you're watching them. And then you probe post the telehealth visit. So that same exact probe, then you teach about the patient, just like you would if you were not on telehealth, and then reinforce what you observed and focus the learner to self-identify things they'd like to improve. So it's the same 5 micro skills, but during a telehealth visit. And the JIT that's on the right is giving them feedback about what we call website manner, or it's really in the literature at this point, their verbal and nonverbal communication skills during a telehealth visit. And we've given them very, very, very specific skills to focus on, and they are tested on this very seriously using the verbal and nonverbal skills during a telehealth visit. But the left is applying the 5 micro skills to the telehealth visit, so it is possible. Any thoughts? So we have lots of these tip sheets that you'll be getting over time. I have foundational ones, and then I have a ton of pediatric ones. So the pediatricians, I have brand new ones. I have ones on how to teach car seat safety, how to teach toilet training. All these pediatricians at Northwell made these for me. How to talk to a patient about bullying. There's a number of them that have come out. So I have over 50 of these, and they all fit on the phone beautifully. And this is what we discussed last time, so I just wanted to remind people who are not with us. And 1-minute preceptor and setting expectations are sort of the 2 topics we've covered, and they really go hand in hand.
How do we get those tip sheets to our phone?
Razia?
We will be sending them to you.
Okay.
My parish will be sending them. Alice has also done the recorded versions of them. So we'll be sending you links to everything tomorrow morning.
Oh, perfect.
So you were on the last call, Joel, weren't you?
Right. Yes, I was.
So you didn't get setting expectations on your phone?
I don't think it came to my phone, but it may have come to my...
No, it comes to your email, but if you open the email on your phone, it fits perfectly on your phone. It's resized automatically.
Oh, okay. That's good to know.
And just to say, all the 11 foundational tips, which is all we're talking about in this program, are all foundational. They all have at the very bottom, there's a little microphone, and you press that and it speaks to you as a podcast.
Oh, wow. Okay.
So you don't have to read it, it will talk to you. Unfortunately, it's my voice.
It's okay.
And then I also tell you I give you an example. So the one on social determinants of health, I give a whole example while I'm explaining it.
Okay.
So the 11 of them have audio, only 11 foundational.
So we have about 5 minutes left. Alice, what we can do, if anyone has any last minute thoughts, we can go ahead and discuss. If not, we can play the video to end our...
So what I'd like everybody to do is to write in the chat perhaps one thing that's a good takeaway for you now, just so we reinforce a little bit. As Mark said, I normally do this, but you're giving me some ideas. Just anything that you feel will stick with you that you might think about a little differently when our student arrives in front of you next time.
Alice, one of the biggest... Hi, sorry, I was with someone who had problems with social determinants of health.
Really?
Yeah. And
introduce yourself, just tell everybody who you are.
I think he froze, but that is Dr. Schiff, who is a pediatric cardiologist, and gives students an amazing experience in his office because they get to work with the echo folks and EKG, but he is hopefully going to be coming back.
There.
I introduced you already, but you can tell us.
I'm at a Northwell computer, so that's why we have issues. So I'm a pediatric cardiologist. The child actually is, his stepdad was here. We don't know where the father is. And his cholesterol, despite being a skinny little boy who supposedly eats healthy, was 350. So was referred, the pediatrician has tried for a while to change things, and he's only 10 years old. So took a while for the visit. But all this stuff is great, Alice, but the biggest problem I have is that the students are only with us for only a few sessions. And, you know, it takes them a while to get comfortable where then you can kind of unleash them. And it's almost like if we would need double the number of sessions to be able to accomplish all of the skills that they really need to get during this rotation. Now, maybe this is just the beginning and they get more of it later on, but it's almost like they're just getting a little taste of this. So we're only going to get to maybe a little bit of what, you know, you have accomplished.
Of course, and this is only their introduction to pediatrics or medicine or surgery or whatever it is, because then they have their third year clerkships. And even during the third year, they have an ambulatory experience. They can choose either internal medicine or pediatrics, right, Razia?
Yes, they can now choose pediatric subspecialties as well.
Right, so they have that. And then fourth year, they have sub-internships and electives. So yes, you're exactly right. This is a step into the environment, but it's not the end all be all. It's a very early step from, you know, I mean, most medical schools are doing early clinical experiences. I do want to brag that I think we do a much more comprehensive one than most, but we wouldn't expect everything at this point.
On that note, I just want to ask everyone if there's no objections. This is only for my own knowledge when I'm 90 years old. That putting the CME credit together, both in person and post, was a huge undertaking. So I'd love to take a picture of this screen if that's okay with everyone.
Sure.
All right, say hello. Thank you, guys. Any other?
Some people are saying they're in a probe more, and that is a step that's omitted many times, the probing. Like you ask the student, okay, great, I think you got it, let's go on, or let's go in and go over what we're going to do, and you don't do that probe. So I think you got what I'm saying with that. I think that's very common. And then making the students more aware of social determinants of health. So thank you.
All right. So in respect for everyone's time, it is 6:30, so I'm going to end the recording, but we can continue discussing.
Be on YouTube when the PowerPoint's uploaded.